Thank goodness for Maggie.
No, the next 3 minutes. Okay.
Thank you for being here. That's what I'll say. Thank you. I wanted to thank Maggie before she sneaks out to her family and other obligations for being everything to us, including tech support, including mental health and all the other types of support, getting us money, all the good things. So before you leave,
Yes.
thank you. Yes, thank you, Maggie. We wouldn't be here without you.
No. She keeps me in line.
It's
Somebody
it's
needs to.
necessary, yes. We would like to respectfully acknowledge that we are on the traditional territory of the Anishinaabe under the terms of the Robinson-Huron Treaty number 61 of 1850 and the Williams Treaties of 1923. We are grateful to be here. We hope you are too. We commit to acknowledge, learn, educate, create opportunity, honor sacred places, and take actions towards real truth and reconciliation in support of our commitment to walking the path together in respect, peace, and harmony for future generations. And with that, we will move on to sexual health, intimacy, and pelvic wellness, which is a huge part of the menopause transition and this time in women's lives. And it's one that is often under discussed with healthcare providers. I went to a recent conference on mature women's health out of Mount Sinai, and they had done a study with like how often does it come up in primary care, and the stats were abysmal about how often it's something that patients feel comfortable talking to their providers about. So hopefully this will help empower you and your friends to just advocate if there are any concerns. And
Okay.
we already did that. Do you want to talk about the agenda?
Sure. So we're just going to talk about GSM, which is Genitourinary Syndrome of Menopause, just the short form. It's a mouthful, so we'll probably just call it GSM, but we'll describe it. Our vaginal and vulvar changes that can happen. Doesn't happen to everybody, but it can happen. It's quite common. Pain with sex, which is common. We're going to talk about all the things, lubricants and moisturizers and things to keep us comfortable, vaginal estrogen, libido changes, pelvic floor health, intimacy and communication, and pelvic organ prolapse. So that's kind of an overview of the things we're going to dive into today.
So understanding GSM. So this was a term we used to call atrophic vaginitis.
It used to be
Literally,
called vaginal atrophy.
Yeah, this is it. Vaginal atrophy as like a medical term that we learned and taught medical students.
Because we're all just shrinking violets.
That's it. A vaginal atrophy. So genitourinary syndrome of menopause is a lot more of a mouthful, but a lot more accurate.
They don't get penile atrophy as a diagnosis, right? They get
erectile dysfunction.
Making it all so manly, but we get atrophy. We're shrinking violets and we're not. So
what is it? Like Angie said, it affects the vagina, the vulva, the bladder, the urethra, the whole pelvic floor. And we have some good kind of images to show and kind of review the anatomy of where everything it is and how menopause can affect those areas. It's most often decline in estrogen, just like most symptoms of menopause. It's common, it's progressive. The good news is it's treatable. We're not shrinking violets, but it doesn't improve without treatment, and that's why we need to start talking about it.
It's one of the big differences, like with menopause itself. After a couple years after the final menstrual period, everything kind of levels out, and you're kind of back to a new normal. It may or may not require treatment for symptoms, whereas genitourinary syndrome of menopause doesn't get better after. It'll just keep declining and getting worse. So it's really important to talk about it.
Yeah. The hot flashes will eventually go away, but this not so much. Oops. how do I go back? So again, what happens when we don't have as much estrogen in our system? Dry vagina, irritation, burning, whether it's from infection or just friction. And that causes pain and discomfort during intercourse, which can be a vicious cycle. Oh, that was painful. How am I going to get geared up for the next time? Which can be both mental and physical. Reduce vaginal lubrication when there's no estrogen around. With the increased friction, there's increased risk of vaginal infections like yeast vaginitis, bacterial vaginosis, and sexually transmitted infections because the tissue is more easily torn. Infections are you're more susceptible to infections because of the tissue integrity that happens after menopause. Frequent urgent urination and recurrent UTIs, which is something that people don't often associate, even though it can be very much a predominant symptom of GSM in menopause. And then pelvic floor muscle weakness causing incontinence. This is a little sad, but true. So premenopause, what you call this, Angie?
What's
The
that?
the juicy.
Estrogen's kind of our juicy hormone. It
The
keeps
juicy
everything
hormone.
plump and full and for those who don't like this word, but moist, wet, that kind of thing.
So that's what estrogen does for our genitourinary symptom. So it has thick epithelium, glycogen rich, thick lining, lots of blood supply and that's in the kind of uterus and endometrium, or the lining of the uterus. In the vagina, before menopause, more lubrication, these rugae or kind of ribs that help the tissue stretch. Pink tissue, healthy elastic tissue that's rich in collagen. And then wah, wah, wah. Post-menopause, what happens? This is science, ladies. The best news is that there's something to do about it, recognizing and treatments available. So what happens? The lack of that rugae or that ribbing, dryness, the tissue becomes more pale looking and less pink on examination, less collagen and elasticity. You can imagine why you could have painful intercourse with these changes in your vagina. The pH goes up, and there's actually a narrowed and shortened vaginal canal after menopause. This is many, 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 many years after menopause, but still it can start within those first years of not having estrogen in your
And
system.
also labia, clitoris, everything is just kind of, the plumpness goes away.
Yeah. And so it's more susceptible to friction, those areas, more susceptible to tearing and pain. And that's with pain with sex. Do you want to talk about this?
You're on.
Oh, I'm on a
Go for it.
Again, a lot of the same. Pain with sex can be caused by a lot of things. The anxiety and pain anticipation that I mentioned earlier. What's vestibular sensitivity, darling? Sorry, I did not see that when I reviewed the slides. We'll get back to you on
Let me
that one.
Google that.
Pelvic floor muscle tension, because that reaction of, oh my gosh, it was painful before, and that causes further tightening and pain. What we talked about, that tissue fragility and dryness, and then low arousal is also a very common symptom of menopause. So obviously it's multifactorial. It's not just dryness, and it can be a vicious cycle. So that's why, again, it's so important to address. So the big things when to see your primary care provider or seek medical assessment. If you are bleeding after you have intercourse, there is good reason to get in and see somebody and to have a good history and physical and assessment. Persistent or worsening pain, symptoms that are not improving with treatment. So actually starting treatment and then no improvement, it's important to follow up. And any new or unusual symptoms that don't seem to quite track or feel normal to you. There's lots of other conditions that can mimic GSM and need proper diagnosis. Like we always say, you need to rule out other stuff. We can't always attribute what symptoms we're having and what mood we're in to menopause. If there's serious symptoms, it's important to have a workup to rule out other causes.
Just,
Oh, yeah.
what I thought it was, but vulvar vestibular sensitivity. So the opening of the vaginas, that's the vestibule that becomes really sensitive, painful to touch.
Yeah, that's like vulvodynia is another word for that.
Yes,
Like
yeah.
the changes of the tissue causing pain because of the lack of
Just
estrogen.
go back for a sec.
Yeah.
We didn't talk about like lichen sclerosis stuff. We forgot to put that in. Do you want to just plug that on?
Oh, yeah, other conditions that can mimic genitourinary symptoms of menopause, like Angie was saying, are something called lichen sclerosis, which is a condition where the tissue gets kind of what we would call hypertrophied or thickened and scaly, which can actually look a lot like the changes that I would see on exam in a vulva that is postmenopausal. But lichen sclerosis is something that is autoimmune, and if left untreated and unrecognized, can lead to increased risk of vulvar cancers. So again, it's important to get checked out if there's changes there that are concerning to you. So first line treatments, I would say before any of this, it's yeah, the mental part, like relationship stuff, mood stuff. Are you sleeping? Back to basics. Are you sleeping? Are you exercising? How's your energy level? How is your relationship with your partner? How is the intimacy? If there is a diagnosis of GSM, the gold standard first line of treatment is to add the estrogen back. There's lots of hesitation around estrogen that we've talked about in previous discussions. Vaginal estrogen is the safest type of estrogen, and it's actually safe long term, even in women who had breast cancer. Of course, it's worthwhile having a conversation with your primary care provider, but it's pretty straightforward. You replenish the estrogen in your vagina, and it can treat the symptoms that you're having. There's other non-hormonal options, which we'll talk a bit more about in a couple of slides, like vaginal moisturizers, which is different than vaginal lubricants that would be specific to sexual intercourse or penetrative intercourse. Pelvic floor physiotherapy. Those women at PhysioWorks are so sick of hearing my name, I'm sure. Lindsay sent me. Lindsay sent me. I send almost all of my menopause patients in menopause or postmenopause to pelvic floor physiotherapy because they address the urinary, the vaginal, the pelvic organ prolapse, the urinary stuff. They address it all. So I feel like that's a wonderful first line therapy. And then it's really important to stimulate the vagina. So whichever way you choose, whether it's manual stimulation using vibrators, having fun with your partner. We're going to get more into that as well. Oh, yes, this lovely picture of all vaginal estrogen comes in a lot of different forms. The big key facts I'm always harping about, if anybody is deciding to go on estrogen, if they have a uterus, they need to be on progesterone as well to protect the lining of the uterus. With vaginal or topical estrogens that go inside the vagina or at the vulva, you don't need the progesterone to offset it because it's local therapy with not a lot of systemic absorption. So it doesn't significantly raise the systemic estrogen levels because of that. Like I said, it's safe for long-term use. It improves tissue health and comfort of intercourse and reduces UTI risk. Symptoms will often return if the treatment is stopped, and it's still underused despite really strong evidence of its safety and its efficacy. I was going to say something else about the vaginal estrogen. There's several different ways, several different preparations, as you can see in those little pictures. So it can be in a cream that you put on an applicator and insert in your vagina nightly for the first 2 weeks, and then typically twice a week ongoing after. So you kind of get a flood of estrogen to kind of get things back up and running, and then twice a week as maintenance. There's a vaginal ring that contains estrogen that you put in there and you leave for 3 months and don't worry about it. It can cause a bit of irritation and sometimes some discharge, but it's way less messy than some of the like cream-based treatments. And then there are ovules that again come with an applicator, and tablets like Vagifem is a very common one that's prescribed, that you insert again every day for the first 2 weeks and then twice weekly thereafter. Side effects, again, it's a pretty safe type of estrogen and way to give your body estrogen, but you can still have irritation, burning, depending on the sensitivity of that area as a side effect. Even though there's little systemic absorption, there can still be like some absorption to the system, which could cause bloating and breast tenderness. They're the most common things I hear of, but generally well tolerated and most certainly effective. There's been lots of patients in my practice who have a renewed sex life after starting this, which is
Or
awesome.
even just, I was gonna say we should not be acutely aware that our labia are rubbing against our underwear. And if we can feel that, it's either we've got bad underwear or it's irritated because the tissues are irritated. So if, those are kind of the same things too. It doesn't have to all be about sex, but if you've had odor changes can impact people. And that's a common thing that happens because of the glycogen and how the estrogen impacts that. But also, yeah, just the comfort. If you're constantly irritated and itchy with or without intimacy, it still works. So we don't have to be intimate to necessarily to have or to want or need estrogen. So it can be helpful for many UTIs, exactly like
Yeah, it just by replenishing the tissues. And again, estrogen is not for everyone. And there might be someone who is very low risk on paper, and I would do an assessment and say, I think it's safe for you to use that. And a personal preference, somebody who has a lower risk tolerance would be like, nope, I don't want that. What are my other options? So
And
more,
there are other options.
there are. So moisturizers are another option that's non-hormonal. We've gotten samples. Again, nobody pays me any money to do this work except our grant, no big pharma. But I've had patients use Repagyne in my practice. It's actual hyaluronic acid, like you would put on your face for like collagen, um, in the vagina, again, twice weekly at bedtime. And it's just the intention is to provide moisture, like putting moisturizing cream on your skin. It using twice weekly improves baseline comfort and hydration. And again, it's not always all about penetrative sex either, right? Like it's just like being comfortable in the world and being able to walk and be comfortable with your underwear on.
Or off, I mean,
or off, whatever you want, whatever floats your boat. And then lubricants, used during sexual activity, obviously to reduce friction and pain. Water-based would often need reapplication, but it works well with sex toys if you're into that sort of thing. And then silicone-based is longer lasting and it can be a little bit better for pain, but not recommended when using certain types of sexual toys. We may or may not have favorites in this list. Angie's favorite is Uberlube, and I haven't tried this before, but it looks like
it's
really.
beautiful. It comes in a lovely glass bottle. It looks nice on your bedside.
And there's a
table.
pump, so you can just
It's
pump
a
that
little
stuff.
pump. It's silicone based. It's got a little bit of vitamin E in it, and I find it's also comfortable just to, post coital or
Post-coitus.
not. It just keeps things because it's silicone. Things just slide really nicely, including your underwear when they're driving you nuts.
I prefer a water-based lube, and Sliquid is our favorite. Right over in the corner there. Yeah, it comes in different types. But there's lots of good ones on the market, besides KY jelly.
And some people like
Coconut
oil. It's just personal preference and what works for you. But I say I plug it all the time. I'm like, use the lube. Like, I think we're taught as young girls that you're supposed to be ready and juicy and wet and everything else, and it does a disservice to us. So it's, I think probably some of us may have had experiences when we were younger when we weren't wet and we were dry and we probably did get tears, and that's going to increase, the pliability of our vaginal wall and increase pain over time. So even young, the younger generation, I'm like, use the lube. Just use the lube. Your vagina will thank you. Use the lube. Yeah.
Oh, I don't know what's
I
going
don't
on.
know what's going on there.
Oh, here we go.
There.
And then the pee stuff. So when we have lack of estrogen in our systems, nocturia, which is getting up at night to pee. Again, I find the pelvic floor physiotherapists we have in our community are amazing at identifying, addressing, and coming up with good treatment plans to help with this symptom. But just like with others, hormonal changes affect the bladder and the urethra. Increased bladder sensitivity, which causes that urgency. I have to go and I have to go now. And then the frequency, like, oh my gosh, I have to go every 30 minutes and like this much comes out. That can be caused by many reasons. Again, rule out UTI, right? Because they can have similar symptoms, but that there is increased bladder sensitivity with those hormonal changes of menopause. We have changes in our sleep patterns. So is it we're having a hot flash, we're waking up, then we're like, oh, if I'm awake, I need to pee, or are we waking up because we need to pee and then not being able to get back to sleep? It definitely affects sleep and vice versa, chicken and egg, pelvic floor dysfunction, as I mentioned, and fluid intake and lifestyle factors. And it's just not a bladder issue. It's often a sleep issue too. So,
And that's what I think if you're looking at your sleep, that's where a sleep journal really comes in handy. It's like that, exactly like Lindsay said. Did I wake up because I had to pee and my bladder was so full, or did I wake up and I'm like, well, I'm up now, I might as well go pee, and kind of track those things. You can start to see trends, and then you can take all that data to your provider and be like, okay, this is what's happening. What do you think is going on?
yeah. Bladder diaries are really important when assessing any issues with urination in this, stage of life. Yeah, this phase. So urinary symptoms, reducing the fluids in the evening. Remember, Angie said at the last session, if you have a coffee at 3 p.m., it's still in your system by 10 or something.
Up to like 12 to 16 hours, I think, depending on the person and how we metabolize it.
So hydration is super important, but you don't want caffeinated beverages most obviously, but most fluids reducing kind of after 6 or 7 can be a common approach. Limiting caffeine or alcohol.
Alcohol, they say about 4 hours before you go to bed to have your last drink. So
Because
not having one right before sleep.
yeah, it can affect, I know it was like, I feel like our parents and grandparents' generation, that's what they did to
A
go
little
to
hot
sleep.
toddy
Yeah, a little hot toddy.
and brandy for you.
But it definitely affects sleep and urination. Empty your bladder before you go to bed. Improve your sleep habits. Did we talk about that in one of our sessions? Cognitive behavioral
Have we
therapy
talked
for
about sleep yet?
insomnia. Yes, super important to address sleep habits. It's like the foundation of wellness, good sleep, good nutrition,
Moving our bodies.
moving our bodies, good social connections. Pelvic floor physio keeps coming up, and vaginal estrogen could improve urinary symptoms. The assessment again is very important.
All right. Sexual function and libido. I could talk about this stuff all day. My kids love it.
Oh yeah, our kids, we were reviewing on Zoom, and like my 13-year-old daughter like came in when we were talking about vibrators, and she's like, oh my God, Mom, you're so embarrassing. Like, I'm going out to the community and talking about this.
Yeah. So it's always important to talk about. Since we've started the women's health clinic, I would say consistently for people who are partnered and even people who aren't currently partnered but maybe looking for a partner, talk a lot about the changes in libido and kind of like that mismatch. It is normal, but as we always talk about, menopause does not happen in a vacuum. It's not always just hormones. Like what else is going on? Like if we've got running kids here and there, or maybe we're taking care of aging parents, or maybe we've just had a big shift in school and we got to create all new learning plans, which when we have to have been teaching for a couple of years, that's different. So we've got a lot going on. There's that allostatic load of stress. So is it just hormones, or is it just, we've got too much going on, or maybe we don't have a supportive partner at home, but we've been such a caretaker that we just have put up with it for a very long time. And all of a sudden we're like, yeah, I don't think I want to put up with this anymore. Or maybe I don't want to be a people pleaser anymore, however that looks for us. So sometimes our desire often shifts from spontaneous. I call this the Michelina syndrome, hot and ready in 5 minutes. That's how we were, like those microwavable dishes.
The Michelina syndrome.
Yeah,
Did you
well,
coin that?
kind of. It's a long story. I'm not going to get into it here, but kind of. But that's when we grow up, these are the messages that we're hearing, right? You're supposed to be spontaneous and ready and always up for, sex anytime and hot and ready, basically in 5 minutes. And maybe we were like that at some point, and maybe we still are like that, but chances are pretty good we're not as much anymore with the allostatic load and everything else going on, but that's totally okay. It's the same for men. They've been brought up to think that they're supposed to be like that. And it's not. Most people actually have more what they call responsive desire. So when you're looking at like, yeah, I've got, how many lists do I have running through my head right now? I'm like, it's going to take you longer than 5 minutes to get my engine revving. We need to, start the foreplay a little earlier. And for women often, maybe some men too, but it's a bit more of a mental game. It's completely normal to have more of the responsive desire. We're not broken because our libidos change. Maybe we're not as spontaneous. That's okay. So responsive desire is common. It's normal. It's actually really common for men too. Society has conditioned us otherwise, unfortunately. This is why we need feminism. So like I said, kind of what affects our libido, obviously stress. I don't know. I'm not interested in anything when I'm stressed to the max. Don't even want to exercise. So, but some of us, that's a good stress reliever. It affects everybody a little bit differently. Pain, like we talked about. So if we're having those uncomfortable symptoms in our vagina or around our vagina, the vulva, we're not going to want to partake in anything like that, probably. And then, like Lindsay said, that anxiety about what's going to happen then kind of comes in, and you just get into this vicious cycle. Fatigue, I'm bagged all the time. Like I'm so tired, right? And it's if my hubby touches me between the hours of 11 and 3, he's getting an elbow in the chops. And this is my best sleeping time, right? And he knows, well, he knows now. He's got a few elbows. Our moods can be up and down with the hormonal changes, and that's distressing enough. Our relationship dynamics, like we kind of touched on, sometimes they're great. We got really supportive partners in our lives, and sometimes we don't. And so we're looking at that. Our hormones do or can play a role in it. I have friends where they've gone the opposite way. It's jacked up their libido going through menopause. So everybody's different, and it's nothing's necessarily normal. Everything can be common. It's just how does it impact you in your life is what the biggest takeaway is.
And history, right? Like what happened when you were a teenager? Have you had any sexual trauma? That definitely can affect
Plays a
libido as
big
well,
role
obviously.
in it. Yeah, yeah. And things kind of come up through this, so like the reverse puberty, right? We can have things that come up and creep up in this time of life that maybe we had suppressed. So hormones do funny things. And obviously sleep. I'm not interested in anything when I'm tired. And the brain chemistry changes. Our dopamine or serotonin, everything's kind of fluctuating. But that, again, nothing happens in a vacuum. We've got our stress, we've got our lack of sleep. Maybe we're living with our parents or our parents are living with us. There could be a bunch of different things that are happening. You finally get the kids out of the house and they just moved back because nobody can afford anything. Right? And you're like, no, nobody can go back to sneaking around our own house. Like, come on. So supporting desire and pleasure is super important. So it's at the bottom there, but I want to put that first. Have self-compassion.
But it's the foundation.
It is the foundation. It just
yes.
says number 5.
Yeah,
Should be
right.
It's okay.
Yeah.
I'm just being wrong. So have self-compassion, being patient with ourselves, trying to understand ourselves a little better. The emotional safety is huge. If we aren't feeling safe in our relationships and at home, obviously that's going to impact everything. And if you aren't safe in your relationships and at home, there is help out there. Make sure you reach out to there's hotlines and stuff like that for intimate partner violence. I always like to talk about that because one of my previous lives, I was a sexual and domestic assault nurse. So it's one of those things is near and dear to my heart and is not talked about often enough. So there is support out there for people. Using supportive tools, like we talked about, use the lube, whatever your favorite choice is. Moisturizers, they're helpful, like moisturize your face, we moisturize our vulva before we go to bed. You know, we pay lots of attention to our face. And the moisturizers are good, but again, it's not the estrogen or the DHEA or other tools to help replenish the estrogen kind of more fix the problem in a sense, whereas the moisturizers are, you know, just like it would be for your face. It's only good for the day or two that you've got it on. Dilators, if there is some, what is it called? Vaginismus.
Pain of the vagina.
Pain and tightness. So people can get very, very constricted and tight. And this is where the pelvic floor physiotherapists come in really handy. And there are vaginal dilators to help try to increase the size and increase the vaginal canal. So they can be helpful. And of course, vaginal hormone therapy, experiment and adapt. You always hear about like swingers and later in life, and I'm not promoting that, but I think there's a reason. I'm not condemning. I'm not going to yuck anybody's yum, but you know, I think we just kind of like get to a point where we're like, I'm gonna try different things. So experimenting, adapting. Sometimes we'll get into it in a bit, but like sex toys and stuff like that, and of course, connection with ourselves. First, we need to connect with ourselves. Some of us are so disconnected from our bodies and ourselves. And also if we have an intimate partner, with our partners, with our friends, just having that, you know, having the people around you that support you and lift you up. So all of that is helpful. We never want to minimize our connections with our friends too.
Ooh. This is my favorite picture, you guys. This is the clitoris. You guys all know this, right? Because it's common knowledge, right? Right?
No.
Right?
It's not. I thought it was just the button. I thought that was this.
That is the tip of the nose of the swan. That is the clitoris. So it literally looks like a swan. And have we showed them this yet?
No.
Angie has something very special to show our live audience today.
My mom is a trooper, and she crocheted me anatomy.
Crocheted the female anatomy, including the beautiful swan clitoris.
She hates it.
Right?
I'm just showing the
Look at this.
online there.
So there it is. The clitoris starts here and has these beautiful little wings, and then
pass it around.
these bulbs underneath. What that means is just as your clitoris is super sensitive, and when it's stimulated, all these areas, which you can kind of get to through the vulva, are equally as erogenous. And
so it's not just about the button.
Yes. And we're just like learning this, like in medical school, this didn't exist for me. And I went to medical school like 20 years ago.
I think it was early 2000s where somebody actually realized that the clitoris was more than just what we could see. Like
knowledge is power, ladies. Knowledge is power.
The bladder, and then the uterus, and this is why when the baby grows, it pushes on your bladder. They can do tap dances, and we've got our
little ovaries.
There's the vaginal canal, the cervix is in there.
Very, very.
My mother hates me because she took it apart about 94 times.
Yeah.
And she said, I'm never doing that again. I'm just going to buy it off Etsy.
It was a labor of love.
She did have a pattern, but she said it wasn't. Yeah. She said it
Isn't
wasn't.
it amazing?
We saw it online. I said, can you make me this? Because she often makes like the bottle holders for the chemo clinic.
This is a little bit more high tech, a little bit more complex than a bottle holder.
Yeah, and I like the 3D portion of it, right? You really get to see how it sits. Oh yeah,
yes.
When we're done, we can take it all apart.
Yeah, there's snaps, like you can remove the parts.
My mom did it, but she will not make another one for
me. Or anyone else.
I tried to get Lindsay's daughter was crocheting for a little while. We're like, let's get Joni to make it.
No way. No way. She said no way. We asked. Like we said earlier, hormonal changes can affect blood flow to the genital tissue, lubrication, arousal, sensitivity, and orgasm intensity. Right. Or sometimes harder to reach orgasm after menopause. and you need more, it's like less sensitive, or yeah, more difficult to achieve climax. Reduced sensation, some women will notice longer time to arousal, difficulty reaching orgasm, and needing more direct stimulation. It's common. It's not a failure. It's just part of growth. So that's why we have toys and things to support sensation and pleasure. So things that help that aren't sex toys are longer warm-up time, more foreplay, like a little bit of flirty flirt beforehand, during sexual encounters, more direct clitoral stimulation. Now you know it's more than just the little nubby. Hands or manual stimulation, vibrators or sexual aids, lubrication and estrogen. This reduces stress and pressure. Sometimes erotica.
We're reducing our stress and pressure, that
Yeah, that's true.
allostatic load of the stress on us, right? Yeah.
That's true. Erotica fiction, porn. It's not all disgusting. There's lots of erotica that's focused on women and women's health and women's anatomy, if you're on the right site. And pleasure often requires different strategies than it did earlier in life. So these are all kinds of different types of vibrators.
There's all kinds of them. That's just a small snippet.
Yeah. And if you go to a sex shop, these people know a lot about these toys.
There's also a friend and who's local, Muskoka Mel. I don't know if anybody's ever come across her, but she's I called her my dildo dealer. But she's like an expert in sexual health and sex toys and things like that. So she's really, really a great resource.
A local lady, that's nice.
She's definitely more than a dildo dealer. She's a wonderful friend and extremely knowledgeable about all things
A
sexual
good resource.
health. And yeah, but she does also sell lingerie and toys and all kinds of stuff. So
Angie and I had, when we were reviewing, had a good chat about this next slide when we were preparing. So when to consider medical support. So when is it like too much, right? So there's this new-ish diagnosis out there called hypoactive sexual desire disorder. So HSDD, and it's the talk of the town, and you read about it in New York Times, and you hear all about it at these menopause conferences that I go to. And I was really curious, like, what makes it a disorder, and where do you cross that line? So we did a little bit of a deep dive, and about the actual diagnostic criteria, it's having changes in your libido that makes you not interested in any type of sexual relations or desire, low desire. But the key is, and it's affecting my relationship, and it's distressing to me enough that it's changing my mood. So it's that, here is the issue, and it's impacting me this much. It's affecting my day-to-day life. I mean, it's very strict criteria, but that was the piece that I was like, okay, what makes it different and what makes it a disorder? It's if it's disordering your life.
Is it in the DSM-5?
Yeah.
Or 8 or whatever it is now?
I think it's 6 now.
6.
Again, we've been talking about erectile dysfunction for decades in medicine, and we haven't been talking about low libido in women. So the research is still behind the times, like for most research in women's health.
Although I will say, so Big Pharma did try to find a drug for female hypoactive sexual disorder. They've tried a million different things apparently, because if it was in a pill, we'd all take it. Probably not all. I shouldn't say we all. That's a terrible thing to say, but people who are, this is distressing enough, would be looking for that. And so they knew that there was a big, market potentially once they figured out Viagra. So they did try. Big Pharma has been trying to come up with a pill for women, but it's just not worked the same.
We're still not quite there. So there's only one medication on Health Canada approved for treating HSDD, and it's not testosterone. Testosterone is approved in the States, where else did we see? In Europe,
the UK, and in
I forget where else.
Australia.
And in Australia. We don't have enough evidence, which is often the case when I'm talking about these treatments. The evidence is not there enough to say, yes, we can use it to treat HSDD, but they are in other countries. So there's lots of menopause specialists in Canada that will try, if it's very distressing for the woman, topical testosterone, one little pea-sized amount behind the knee a day. That is not mainstream in Canada now. I would be shocked if any primary care provider in Muskoka would prescribe it. But I really feel like at this conference I went to 2 weeks ago, it was all the talk amongst all the leading experts. So I feel like there's, again, like most things, it's coming down the pipeline and it could be a viable treatment in the coming years. This flibanserin is on label, Health Canada approved. Brand name is ADDYI, ADDYI. It's not popular. There's lots of side effects, and you have to take it for 3 months before there's been any significant noticeable change in the literature. So I may be doing it an injustice, but it's not something that we regularly prescribe. And the women who have tried it haven't had success in my practice, or just don't end up staying on it long enough to notice a difference. So there's not a lot, is the bottom line, to help with this issue. That's why doing all the other lifestyle things and the other treatments to help support your system is so important. Oh my God, we still have pelvic health to
No, we
talk
got
about.
time. We got time.
Okay.
We booked, I
Oh,
think,
yay.
an hour and a half for these ones because we condensed the.
Yes.
fun.
Oh, this is not mine.
Yeah.
My phone was just ringing. Sorry. I just want to make sure it's not a kid.
Yeah.
Okay. Oh yeah, this is awesome. This is the anatomy in a cartoon, right? So it's good like our 3D model crocheted or this visual. When you find the changes in menopause coming, it's important to understand the underlying anatomy. So this is your pelvic floor, the muscles that are holding up all the organs, your pubic bone, and then it's bladder, vagina, and uterus, rectum, bowel, and spine. And if the pelvic floor falls, you can imagine these organs can kind of fall in on one another. The pelvic floor, we had Brittany and Carolyn come and speak last year and do this talk, and they are just incredible educators. The pelvic floor does a heck of a lot. And
They're definitely the experts.
they're definitely the experts. I would highly recommend them. Supports bladder, bowel, uterus, sexual function, and core stability. What can happen if we have pelvic floor issues? Leaking urine, like stress incontinence, women jumping on a trampoline after giving birth.
4 jumps and I'm done.
Yeah.
Kids are like, do you just went pee? I'm like, I don't know where it's coming from. But I got 4 jumps in. That's all you got.
A urinary urgency, again, like we talked about, pain with sex, because of the laxity in that musculature that holds everything up. It can change the anatomy and make intercourse and other sexual practices give it more discomfort. Pelvic pressure or heaviness is often a symptom that I hear patients complain of, this heaviness, like things are falling, a bulging sensation, depending on the degree of prolapse and what's prolapsing, which we'll get into. You can actually feel something. It's like some women come feeling like part of their insides on the outside on their underwear. Like if they've had a hysterectomy, it could be their vagina or part of their bladder. And it can be very distressing, as you can imagine. Difficulty emptying the bowel and bladder because they kind of fall into one another, so they're not as straight and easy to empty. And then low back pain with laxity of the pelvic floor. It interacts with the entire core and then some, and it can increase your risk of back pain.
It's not just laxity. Some of us are already very tense. So I'm gonna steal from Carolyn and Brittany when they came to do their chat on the pelvic floor. Carolyn and Brittany, pelvic floor physiotherapists in town. So Carolyn had said, think of like flexing your bicep, right? So you're constantly flexed like that. Just try to flex it more. You can't flex it more. So if you're already very tense, and you've got and we're, as women, we're taught suck your stomach in, keep everything nice and tight, right? Like from a young age. And so we're always keeping everything tight and tense and contracted. So when you do like jump on a trampoline or go to sneeze, you can't tighten anymore to contract to keep that urine from leaking. So she said sometimes, and this is why it's important, I think, to also get an assessment by somebody who, like a pelvic floor physiotherapist, because you could need to learn to relax the area first and then maybe work on Kegels and stuff like that. So jumping right to Kegels or to an Emsella chair or something like that isn't always the answer. So it's assessments are good. If you've got leakage or bladder problems or things like that, an assessment by somebody who's, adept at, not me, assessing, and can help you navigate that.
That tightness, yeah, exactly. So it's not just laxity. The tightness, we can see it in athletes, high performance athletes, gymnasts, horseback riders, strong core, strong musculature, even postmenopausally, that over strong or like this too strong pelvic floor can cause many of the similar issues as too lax. So I agree with you, having a proper assessment to see what needs to be relaxed as a part of your pelvic floor, because it's a very intricate jumble, well-organized jumble of muscles, and what to relax and what to tighten up. And Kegels just doesn't cut it for most of us because it's more nuanced than that. Pelvic organ prolapse, it's very common in women who've had vaginal deliveries and also women who've not had any kids. Postmenopausal, usually like 70s-ish would be an average age. It could involve the bladder falling, which is an anterior vaginal wall, if you can remember that anatomy, the front of the vagina. The bladder kind of falls into the space where the vagina is. It's not actually falling in, but it's pressing against the anterior wall of the vagina. And if it falls, it's harder to empty, if you can imagine, right? So it can cause lots of issues and heaviness. The rectum is the posterior, the back wall of the vagina, right up against it. So with pelvic floor prolapse, the rectum can fall into the vagina, which can cause issues with bowel movements. Oh, we don't have a rectum.
We don't, I know.
That's okay. We have a bladder.
One of my dad's old jokes, rectum damn near killed him. Sorry.
The uterus can actually fall. Like there's been women where they complain of something rubbing up against their underwear, like a woman in her mid-70s, for example. And I look and I can see her cervix without any instrumentation because everything is just kind of fallen. And then what's more common is if somebody's had a hysterectomy, so removed their uterus, there's no large organ kind of holding things up. So it can be common for a vaginal vault, or what's left of that organ system, the vagina and a blind end can also fall with pelvic floor. It's caused by weakening of the pelvic floor, muscles, ligaments, and connective tissue, and can be linked to postmenopause. So these are the images that we were just talking about. So cystocele, you can see the bladder kind of falls in. This is the vagina, and that is the bladder. So cystocele, or anterior vaginal wall prolapse, is the other name. This is the rectocele, where the rectum kind of falls in because of the pelvic laxity. And you can imagine how that could cause issues with emptying. A uterine prolapse, like I just mentioned, that's what I would have seen on exam for a like grade 3 uterine prolapse, a cervix looking at me. And then enterocele I've never seen or heard of, and I hope I never do. This is when other parts of the bowel kind of creep down in front of the rectum. Very uncommon, thankfully. We have enough to worry about.
A new nurse working in the emergency department, and we had an elderly woman in one of the bays, and unfortunately her gown was up, and I was at a distance, and I had no idea this stuff could happen. They don't teach you this stuff in nursing school anyway. And I looked and I was like, is that a penis? I said to my like one of the nurses I was working with, it's like, what is happening? And she says, no, that's a cervix. It was right outside, like I could see it plain as day from 20
These
feet
poor
away.
women.
Yeah, and I was like, oh my gosh, that could happen. I think right there I was like, Kegel, 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 like every stoplight, I thought, I don't ever want that to happen, but we're not taught that stuff when we're younger. And it's important to talk about it. So I always like with the young women in our lives, like these are the things that can happen. So I sometimes jumping to like, we all might want our uterus removed because we're tired of it and we've been bleeding like a stuck pig for the last 5 years.
But there could be consequences or risks.
Yeah, so it's not always the first go-to. I mean, obviously can need to be at times required. But there's other consequences that could happen. So
And can I say this doesn't happen to everyone?
no,
So please don't worry
it's
too
not to
much.
scare you, but
It's
it's
not
just
to
like,
scare you,
oh,
just to make you aware.
what is
There,
that?
50% of women
Yeah.
have some degree. First degree prolapse would be still well above, just a little bit of a fall. Third degree is kind of getting to the opening of the vagina, being able to see either the anterior wall of the vagina or the posterior wall. And then grade 4 is things are just kind of hanging out. Only a small number actually have symptoms. So 50% of women have it, and a lot of women don't even have symptoms. So they don't realize it. I like that. They don't realize what they're feeling actually has a name, and symptoms may be subtle or dismissed. But that's the time to kind of get going at the earliest signs to see a pelvic floor specialist and get a treatment plan going. Do you want to talk about this?
Yeah, sure. So it can feel like we kind of talked about it, that pressure or heaviness that you can feel in the area. So, or if you cough or sneeze, you're like, I don't normally feel something, with that extra pressure in your belly pushing down. You don't normally feel something in your vagina or in your underwear, like Lindsay had said. Now all of a sudden you're feeling that, or you just have a constant feeling of a pressure, a bulge, like you can actually feel or see a bulge, maybe yourself. I've always been a proponent, even with the kids. I'm like, get a mirror and look at yourself. Get to know what your anatomy looks like. We aren't taught that as kids, especially as young girls. And you want to know, you want to be inspecting, you want to be looking, especially like Lindsay said, if you have something like lichen sclerosis, if you're noticing changes of your labia or anything like that, we want to get it checked out. So to get a mirror, look at ourselves in the mirror, especially like if you're thinking, well, every time I cough or sneeze, I think I feel a little something, get in front of the mirror, give yourself a little cough or sneeze and see if something comes out that's not supposed to be there, because maybe it's just with that extra pressure. You could have some discomfort with standing or with activity. And like Lindsay talked about, difficulty emptying the bladder bowels because it's not in the right spot. So then you're going to have, urine left in the bladder, and that can increase your risk of urinary tract infections. You can have stool that sits in the rectum, which is uncomfortable, and you just feel like you're not, if you with the rectocele, that you're just not fully emptying. This could be an issue. Maybe you think I'm always constipated, but I don't feel constipated. I just don't feel like I've emptied. And of course, sexual discomfort can occur because things just weren't in the same position as they were. So if you get new pains, you feel like, well, I didn't used to have a pain there before. What's going on?
I've seen women in my office. It's not uncommon for women in their 60s, 70s, and 80s to coming in saying, I have a urinary tract infection and I'd like treatment. So that's their chief complaint. And and then I go back in their chart and I'm like, oh yeah, 3 months ago you had these same symptoms and we did a urine culture and it was negative, normal, no bacteria growing. Oh, and 6 months ago, look, you had another one and someone gave you antibiotics because of your symptoms, when actually it was the pelvic floor dysfunction and a cystocele that was causing the pressure, because suprapubic pressure, frequency, and urgency are the three most common symptoms of a urinary tract infection. It's usually that, but it's something that I've started thinking a lot more about when these patients are coming in with recurrent symptoms without the actual UTI diagnosis in the end. It can often be something related to their pelvic floor dysfunction.
I'm sorry, did we say UTI is urinary tract infection? And a lot of us know what that is because they're very common, but
Yeah.
sometimes I get used to using acronyms and I shouldn't.
Yes, bladder infection,
Bladder
urinary.
infection, yeah. And so often there's a silent impact, and this is where I think it's really important that we need to advocate for ourselves. It can affect our confidence and our body image, our sexual health, as we've talked about, our daily activities. If it hurts, if you are leaking all the time, you're not going to want to run. You're not going to want to like work out, do those things. Exercise participation, our social engagement. There's great pads out, like incontinence products. I shouldn't say pads. That we're not supposed to use pads, menstrual pads for incontinence.
Yes.
Supposed to use specific incontinence pads, but some people feel very embarrassed. Sometimes there's odor, people don't like that. So then you reduce your circle. You don't go out and see your friends. You don't go out and do the things that you want to do and you like to do, because this can really impact people's life. It can make people feel very isolated.
But there are treatment options.
There are
This
treatment
is not the end of the world, the end of the line.
And we often don't talk about it. Maybe we don't know to talk about it. We don't know what it is, and we don't think to ask, or we're embarrassed, or maybe we don't have the greatest relationship with our physician. And some of us just say, oh, this is just the way it is. My mom had it. Everybody just has it. This is just part of aging. It can be, but it's not for everybody. It's common. Do we call it normal? Not necessarily. Normal is a setting on a dryer. It can be common though, but it also is treatable, which is the most important thing.
Good question.
Yeah, the incontinence pads are more absorbent. So you can get, I think it's called Poise, right? But they have like full like pull-up style ones, but they also have actual what look like menstrual pads, but the menstrual pads don't absorb as well as the incontinence pads do. So if you don't need a lot, if it's just like a bit of an urgency and you're not fully releasing your full bladder, like that's when maybe you need more of the pull-up style ones, a bit more coverage. But where the Poise pads themselves are more just like, oh, I had a sneeze. That's a little more than I wanted. And yeah, but the menstrual pads keep the moisture against the skin, and then you end up with skin breakdown. And that's not comfortable. Nobody likes the rashes.
No. My mom used to call them my pee pads. Where are my pee pads? Where are my pee pads? I need to put them in my purse before I go anywhere.
Yeah, I call there's another brand called Depends. And I said I call it Depends because it depends on whether they make it to the bathroom or not. I don't think that's why it's called that, but that's why I tell people that because it emerged, trying to keep people's dignity, and I like to make a little bit of jokes because, it just keeps things light. But I'm like, they're like, can I have a diaper? I'm like, it's not a diaper. It's called Depends because it just depends on whether you make it to the bathroom or not. I usually get a good chuckle. So some of our risk factors, like we talked about, it does happen with aging. Our collagen decreases. Collagen helps keep everything, together. So our knees start to hurt. Everything starts to fall. Everything goes south. Menopause, because of the estrogen changes, pregnancy and vaginal deliveries. And sometimes depending on how much weight you gained with your pregnancies, you could have maybe just had one, but if you put on 100 pounds, that puts a lot of extra pressure on all your organs. Chronic constipation.
You can imagine, right? Straining often, straining to go.
And then the walls of the rectum, just like your blood vessels and stuff, they just start to pouch out. They're like giving up. Like, fine, would you eat more fiber?
And that's what a hemorrhoid is. And that's what a hemorrhoid is.
Yes.
Right?
Yeah. Yeah. Heavy lifting. So you work on a farm or you lift kids or you're exercising, especially if you're new to weight training, which I think a lot of us should be. If it's new to us, go out and do that. Obesity itself, again, because you've got all that extra weight and the pressure and the visceral fat, it'll press down on the organs, and the connective tissue changes like we talked about. So reduced collagen, unfortunately. And I don't know if collagen will actually, like supplements will actually help that. So, and just because it's common doesn't mean it's normal. I don't know if this, I liked that. I did not fact check the bottom. I'm just gonna say that right now. I just liked the little meme here or thing.
Let's hope it's fact checked, and because that's a great stat.
It is. And I think it is. 80% of women with pelvic floor problems can be successfully treated, which is probably true. You just got to make sure we're staying on top of it. Really. Yeah, I should have just made my own and took that out because I didn't fact check it.
So treatment options, if it's not bothersome, don't worry about it. Just be aware of what to look for. And if it does become an issue, address it. Pessaries. So we insert and fit pessaries in our menopause clinic. We don't have a picture of a pessary. I usually have one in my bag.
A pessary itself?
Yes.
Oh, or a picture of one.
No, a real one. So plastic, rounded edges, device about this big. Well, there's varying sizes. That's why you need a fitting to see what fits in your unique pelvis. It supports the organs internally. So you put it in the vagina, you curl it up like a taco, insert it in the vagina. It opens up and literally holds everything up, like holds everything above the bladder and the rectum. We can fit them in clinic. Many of our family doctors do pessary support and care, and it's a really good non-surgical option. A lot of these women are elderly with multiple comorbidities, maybe not even interested in going into an OR at all. So this is a great first line treatment for non-surgical. It doesn't work as well with the grade 3 and grade 4 prolapse when it's actually outside of the body. It doesn't seem to work as well, which makes sense. But it's a really great option for women. Of course, pelvic floor physiotherapy, we can't harp on it enough. That's usually my first line. With patients is seeing a pelvic floor physiotherapist, getting a good assessment, getting a home exercise routine that can help support your unique anatomy, and then lifestyle changes like the fluid stuff we talked about, good bowel health, regular soft bowel movements, avoiding heavy lifting, that sort of thing. Surgery is a last option. One of these discussions that I listened to at the conference a couple weeks ago was there's less and less and less urogynecologists. Urogynecologists are who perform these surgical procedures. And for the amount of demand versus the amount of people who are actually practicing it, there's a giant discrepancy. So women are waiting like 2, 3, 4 years for referrals. Our closest one is in Collingwood. There's no one in Aurelia doing it anymore. Barrie, I don't think either. So it's really hard to access. But luckily, it's like the last resort option is surgery. They do something called the birch sling where they go in laparoscopically with the cameras and kind of hoist things up and tie it back up together, lift up your uterus and kind of attach it to the ligaments in the pelvis. Oh, obliterative. What is that? I don't want any of my patients to have that option. Obliterative therapy for those not prioritizing intercourse. Well, that's just taking everything.
Sounds like it.
Not a common thing.
No.
Wouldn't recommend it. There's lots of other conservative things that we can do that can really
just have
help.
one little anecdote thing on the pessary. So it was viral for a little while. There's a woman who was a nurse. I can't remember, she was on a urological floor or something. It was a video that she made, and she maybe she was an emerge nurse. There's a woman who used a potato as a pessary. We're not going to recommend using potatoes as a pessary. But she'd had it in there for however long. She's like, no, I'm just using the potato as a
It
pessary.
kept everything up.
It did.
Wow.
It did. So don't use a potato as a
No.
pessary.
With the pessaries, they usually cost like $70. So once you get it fitted, we'll order one in for you, and then you can learn to put it in on your own, and it only needs to be taken out once every 3 months. That the caveat is if you want to engage in penetrative intercourse. I've heard some really interesting stories about pessaries and intercourse. So you might want to remove it for sexual, like penetrative intercourse. But it's good. You take it out once every 3 months, wash it with soap and water, and then put it back in. Side effects and risks, irritation of the tissue that it's up against, and your body can produce more discharge as a response to having something foreign in your vagina. But usually really well tolerated, and it makes a huge difference in the right patient. Yes. Good question. Self-referral. So pelvic floor physio, Health Canada, is covered in France for all women. Here, physio has been delisted as something that's OHIP covered, and only in very particular cases like post knee replacement, post hip replacement, you can get some OHIP covered physio, but Physio conventionally is not covered any longer, which is really unfortunate. Most plans, if you have insurance, will cover it. So if you have an insurance plan that covers physiotherapy, they'll cover pelvic floor physio, and it depends on your insurance program whether you need a doctor's note or not. You do not need a referral to our pelvic floor physio. You can just call and book it on your own. They're busy and you pay out of pocket. Exactly.
But they do have what's the new program? The research pilots that they're doing. They've created some videos for women to try to make it more accessible and walk them through a pelvic floor exercise kind of program, because not every woman can afford what it costs to go to physiotherapy, and not everybody has coverage.
Yeah, so through our family health team. So if you're a member of our family health team, either with a nurse practitioner or family doctor, eventually the initial pilot was just for postpartum women doing pelvic floor physio, but it's expanding and they have modules on incontinence, pelvic organ prolapse, good bowel habits, and that's going to be widely accessible and free access to people who are a part of the family health team. I think eventually with the goal of having access for everyone in Muskoka. So online videos made by Brittany and Carolyn Van Dyken of PhysioWorks in our community. They're excellent. So if you do have a primary care provider, you can ask for access to them. And most doctors are learning how to give that information and share with their patients. And if you really want access, you can also come to me or email Maggie, and I can try to get you hooked up.
And I was at school with teachers who said, "Oh, God, I've seen this women." But they were so amazing then, and I've seen them a few times since. But I was having serious back trouble, and there's a 7-minute video that Carolyn that's
Carolyn, yeah.
And I was like, I need to see a physiotherapist, and Alan, the yoga teacher, said, "Why? Someone new, you already have them." And so it's a 7-minute video, and she does it in her jeans, in her kitchen, holding her sink in her counter. 7 minutes in the morning, I swear to God, if I do that, I haven't done it in a while, and I know I'm in so much lower back pain. It's miraculous.
They're brilliant.
It's not like you need a yoga mat. It's not like you're gonna sweat. It's like you get up in the morning and you can pour your cup of tea and hold on to your sink. 7 minutes, it changed my life. When I was doing it regularly, it's unbelievable.
Because pelvic floor connected to low back, they do a lot of low back work as well, hip work. So they're a wonderful resource.
Yeah.
And what I love about their approach to treating clients is it's not just a physical exam and a history. I went just out of curiosity, and they really take stock. They go through your mental health, your sleep patterns, your urinary, really thorough intake. On many different emotional, spiritual, physical levels.
Nutrition.
Nutrition.
A lot about bowel health, especially, and fiber.
We can't say enough. And again, they don't give us any money to say this to you. We just think they're great. Yeah. And we're so lucky to have them.
And I love that they recognize that it's not available to all women. It's a fee for service. So trying to just like we are, getting research grants to make it accessible to more women. Ideally, you can go in and see them and get a proper assessment, but not everybody has the money to do that. So they're making, what they can available, and that is near and dear to my heart. So I was
working on increased accessibility. Yeah. When they first arrived in town, they came to our office and they're like, "Can we do a slideshow and tell you about what we do as pelvic floor physios?" And we were all so cynical. It's embarrassing to think back. We're like, pelvic floor physio. And this, Carolyn, the mom, she's just so scientifically oriented and evidence-based, and she's an educator and she has her master. She just knows her stuff, and she just blew up. It's been a huge paradigm shift in kind of approach to women's health. And I'm so grateful that they're in our community supporting our women and men. They see men as well. Yeah. Can't say enough good stuff. Well, important considerations. We're going to treat based on symptoms, not what we see on an exam, because it depends on how you feel and how much it's impacting your life. Like I said, many women can be managed without surgery. There's lots of conservative approaches and lifestyle changes that can help. Pessary as well. Pelvic floor physio is often the first line. And not all prolapses need intervention. I think we said all that. And if we said all that, look, it's not just Kegels. Sometimes muscles need to relax, not strengthen. Oh my gosh. Now we talk about, I thought we already talked about intimacy. Oh, beyond intercourse. Yes, that's important.
It is. It's
Yeah.
not all about intercourse, despite what the patriarchal tells us. Down with the patriarchy.
Yeah. Yeah, so we did a grand rounds in front of all the physicians in September, telling them about what we're up to and what's happening and how to refer.
6 years. Find this by myself, and I've gotten zero help. Even after complaining and telling my symptoms, and this is just very upsetting for me
To have to find it yourself and not to have a provider that can give you.
And when I told my doctor to make the appointment, I said, I have the referral form. He said, yeah, we know, we have them here. But never once was it.
It never came up in your appointments at
I'm
all.
sorry for that experience. We did talk about wanting to do more education with our providers as well.
Yeah. And I feel like, again, another paradigm shift in that a lot of the younger docs that are coming out are much more educated and skilled at diagnosing, addressing, and knowing treatment options for women in the transition and post-menopause.
Hopefully not as dismissive.
And
as
hopefully
some-
not. It's very sad that it would be quicker if you just found your own help. It's unfortunate. We're, again, continuing to do education with our medical colleague.
that feedback is so important for us because we want to know where the gaps are.
Yeah.
But we also want to be sure that that the physicians are making a proper referral. Like we can kind of see the health hub as a stepping stone, a little bit above maybe what your primary care provider is able to provide, but we're not gynecologists. We can't do specialist stuff. If somebody's got a complicated history, we're not going to prescribe outside of the Canadian guidelines. So some people, we still need referrals to gynecology, which can be an hour, I wish, a year.
Would that be nice?
Endocrinology, rheumatology, stuff like that. So, but we can also assess that in the clinic and give feedback to the physician or the nurse practitioner and say, hey, this wasn't necessarily the appropriate referral for us, but we've sent off a referral to whatever specialist we feel you need as well. Yeah, so thank you for providing that feedback.
Yeah.
I'm sorry for that experience. Yeah.
We have
12 months without a period, and my doctor told me that I could be in menopause. I was too young.
Ah, yes, the too young.
It's really disappointing to hear.
Yeah.
I hope the tides are changing. I really have high hopes that they will. And as an update for our Women's Health Hub clinic, we have 40 women on the wait list right now. So we actually had to put a little cap on referrals for the time being. And then in September, when we find out if we have more grant money coming, we will open it up again. So if there's anyone that that has recently gone through the process and got a referral, we actually decline it just because of wait list. We have to get through the wait list over the spring and the summer.
Are we keeping those referrals though, or
Oh, yeah.
does the physician have to send a new?
Yeah, no, if we have the referrals, we're holding on to those 45. And for now, we're just saying, no, we're not taking more until September.
Okay.
Yeah.
We could get form filled out.
Give me your info afterwards. Yeah, I think it's high time you get some attention.
Yeah, sadly, it's just once a month. It'd be great to have it.
But we have a couple
Once
more
a week.
providers
We do.
that are joining us. So Helen Dempster.
So
who's
if
a
anybody
wonderful
has Helen
physician.
Dempster as a doctor, you don't need to come see
Yeah.
us. She's phenomenal.
Yeah. And,
You can
and,
still come.
and Dr. Bozak is going to join us hopefully in the fall. So we have a couple of new amazing women who are
And
going to be helping out.
Nurse practitioner.
And Terry Bullen, a nurse practitioner in town, is very interested in helping out. So we have good people. We just need more time to see the people who are waiting to be seen. So that's just a little update. More info to be coming down the pipeline
Yeah.
once we get through the list of 40.
Oh, I'd all like to work. We'd have to work 12 hours a day.
In addition
I'd
to the
love
other
to do that.
things, I know.
Yeah, I'd like to do it all.
Yeah.
Okay, yes. Any other questions right now before we move on? All right. So what was this part again?
We're talking about intimacy.
Are we?
Yeah.
Intimacy
Oh,
beyond
yeah.
intercourse, right?
I'm glad that you have,
Yeah.
I saw what.
Okay, so communication tools. So communication is key. But this always starts with, if we're looking at intimacy and if it is impacting our life and what's going on, opening those channels with our partner, especially if they're supportive and loving. Try not to be afraid of it. It's awkward, but those kinds of communication is super important when it comes to intimacy. So it feels different for me. Can we talk about it? Can we slow down? Can we get more lube?
Get the pump.
Get the pump. And maybe if things have shifted, like I want to explore something different, like we talked about that experimenting, or explore something different for me now. Things are a little bit different. I'm not 25 anymore. I'm not feeling the same as I was. So opening those lines of communication. I can't speak to this provider directly because I haven't heard any feedback, but there is a newer therapist in town who is specializing in sex and intimacy, as well as I think probably beyond that. Riley, I think her name is. Yeah, so I can't speak to, like, I've not gone myself. I haven't heard any reviews yet, but I think it's a great asset to our community. So working with the LGBTQ community, and yeah, so very good resource, because sometimes
positive.
yeah, and sex therapy is sometimes what we need as well, right? To have a good sex therapist in our corner might help also. So I like to gather kind of the resources in our communities, because I'm not the expert on the subject, but I like to be able to where to send people and make sure we have those resources. So
I'm just going to quickly.
Yes,
The vaginal estrogen isn't the be all end all in terms of like treatments as well. There is also a DHEA, which is a type of testosterone, but actually converts to estrogen and progesterone once it's in the vagina. And I think it's an ovule that you can insert. That doesn't have the same risks as estrogen in somebody who's had maybe a estrogen receptor positive breast cancer that might feel hesitant to use vaginal estrogen. And then the ospemifene is an oral medication that helps with genitourinary symptoms of menopause. It's a selective estrogen receptor module. So it's a SERM, it's called, and it's still hormone, but doesn't have the estrogen effects that can increase your risk of breast cancer as much as the estrogen would. And again, I still will say that vaginal estrogen is very low risk and high in efficacy, but there are people that are going to want to try estrogen, so there are other options. And I'm glad that it was on this slide because I forgot to mention it earlier.
Yeah, reduce friction. I can't say this enough. Use the lube. Including vibrators or manual stimulation. So again, maybe going outside of our comfort zone, purchasing toys. I think Shoppers Drug Mart even has a couple little vibrators on the shelf. Like you don't have to.
The other day.
Yeah, so they're accessible.
They're called massagers.
Yeah, massagers. You can order them.
Personal massager. Shoppers in Huntsville. I was like, on the clearance rack. I was like, what? Oh dear. People really got secondhand. That's all.
Yeah, that just took me down a weird rabbit hole in my head. I'm just
avoid. Yeah, don't.
An interesting yard sale. There was a swing. I've never seen that kind of swing before.
Oh, funny.
I think somebody had posted that on Facebook. but as a joke, but it was a sex swing, and they had posted as on Facebook Marketplace as like a swing for people to use out in their front yard. It was funny. Daily comfort, again, moisturizers, pelvic floor physiotherapy, communication. So all of this stuff can be helpful. Finding the help you need, right? Where are the resources? So if your doctor's not listening to you, I have this one story that I told during our last sessions. There was a woman who told me that she was around 62 years old, was still sexually active, wanted to enjoy intimacy with her husband, but was having significant vaginal discomfort and pain, and was referred. And fortunately, her family physician didn't provide the vaginal estrogen. I guess it wasn't on the top of their radar. Referred to a gynecologist, and the gynecologist said, "Well, you've had a good run, hun." It was a male gynecologist, not that they're all bad, but so being dismissed, like I always like to flip that script. If a man went in and said, every time I put on my underwear, my penis is really sore, like it rubs against it, it's always kind of just like this, like at 62, are they gonna say, oh, well, you've had a good run, don't worry about it? No. So why would you say that to a woman when she's experiencing it, right? So this is why why we're doing this kind of education too, because it does happen. Women especially are dismissed all the time. And so we need to talk about it. Talk about the taboo stuff. So we deserve comfort and pleasure. It's not all about pleasure, but if that's your thing, we deserve to feel comfortable while we have pleasure. We deserve to feel comfortable walking around in our daily lives. And as our sexuality maybe evolves, it doesn't end. There are things that we can do. Our comfort and our pleasure and our connection matter, and we deserve all three. So advocating for yourself at home, advocating for yourself, with our family physicians and nurse practitioners and the people that we surround ourselves with, and talking about it with our friends, opening that conversation, talking about it with our young women in our lives. Maybe the teenagers might be a little like, oh gosh. But
Every time,
20s or so.
every time I do a pelvic exam on a woman, whether it's doing her PAP, it's standard to check like, so do you have a sex life? Do you have a partner? Do you have penetrative intercourse? Is it comfortable? A lot of women are like, nope, I don't have it. I don't do it. I'm like, is it because you don't want to, or is it because you have other ways of having intimacy with your partner or significant other? And sometimes it's like, yeah, we don't have it. He doesn't get erections, or I have no interest, but we really love each other and we show our intimacy in other ways by cuddling on the couch. It just depends on if it's something that you want in your life or something that you feel like you're missing, or something that symptoms are inhibiting you from exploring, right? So a lot of women are happy not having sex, and that's okay. But if it's because of pain, because of their last experience, there are so many things that we can do to help. And you do deserve all three. Oh, yes. Here's our books.
Some of the books we love. Better Sex Through Mindfulness. So Dr. Lori Brotto is a researcher out of, I think it's UBC. She's a Canadian researcher, does a lot of research on women and sex and libido and stuff. And she's written this awesome book. It actually comes with a companion guide. I think I only have the companion guide because I think I listened to that on Audible. I didn't buy both. So yeah, it's just basically talking about more of that mindfulness and how that kind of shifts, especially for women. I got the list of the ticker tape of things I got to do running through my head. I'm probably not into it. You get me out of my head first, right? So
Come As You Are
yes.
is an awesome book. Yeah. Emily Nagoski has her PhD, and she's a sex therapist and like scientist. It's really entertaining. It's super informative and educational. We love Emily Nagoski. She wrote 2 of these books. I haven't read Come Together, but I loved Come As You Are.
I haven't read it yet either. She's also got another one called, I think it's called Burnout. It's phenomenal. Her and her sister wrote it. Her sister's a musician, and they did a really good job.
I love that book too.
It's just Burnout, isn't it?
Yeah,
it's really good.
Did anybody check out Jen Gunter's webinar that we sent an email around? Did you guys see it? It was it was so busy that you couldn't even get into the webinar. So you had to go to like, by the time I tried to log in, I had to go to like a YouTube site. It was like live
Yeah.
YouTube or something. Anyway, it was fabulous. If I have, yeah, if I can find it was great. It was great. And it was for the public. Like it was not geared towards medical professionals. It was for the public, and she did an awesome job. So yeah, if I can get my hands on that, I'll make sure it goes around.
And that website, that's UBC as well, isn't it?
Yeah.
Or UVic?
Yeah, I think it was
It's
UBC.
They've
Yeah.
got a whole, like, I went down the rabbit hole,
Mhm.
a whole women's health section, which is really good, and lots of different topics. I think I signed up for one, it's on osteoporosis and soft bones, I think they call it. So all kinds of different things yeah, so did I. So they've got all these awesome webinars for women's health. Women's College also has some really great information on their site, I believe, as well, if I went down that rabbit hole.
There's really good resources.
Yeah.
And if you, we should send some of our favorite. Gynae QI is another one that I love. It's a gynae collaborative through the Society of Obstetricians and Gynecologists of Canada. And it has a menopause section, it has a PCOS section, it has an endometriosis section, and tons of good, reputable information and education on lots of women's health topics. Highly recommend it. So I'll put that through on in our follow-up email. Shelley, do you have any questions? I got the teacher. I got the teacher.
No, we just get,
yeah.
That website.
It's okay. We're just kidding.
I'm teasing. I had to.
This is adult learning.
Yes.
Okay.
All good. Every naked person I see turns me on. I love this. I think Maggie found that
Maggie
one.
did find that. That's cute.
Yeah.
And if you haven't already, please do. I don't know if you did the pre-session questionnaire, but I think we forgot to mention it.
Did
Anyways,
everyone
it's
here
there.
do the pre-session questionnaire? Awesome.
It was at the front and it was on the email. We just forgot to mention it, but that's okay.
Tell me when you're done, Tammy. I'm gonna go to the
Go to the
first
people.
one.
Yeah, yeah.
Yeah.
I
Yeah.
think she
And
does.
you get the emails because the pre-session one on the 7th, like last week, it would have no.
Was, it said there was going to be another session on May 13th.
Okay.
Okay.
Yeah.
Good.
Please give me your info before you go. Thanks for coming out on a rainy
I'm
Wednesday.
just going to in the chat. Does anybody online have any questions before we say goodbye?
Does anyone here have any questions
Yeah.
while we're waiting? Feel free to come and chat with us afterwards.
Mm-hmm.
I don't know when our next one is. I don't know if it's
I
in the
think
books
it's
yet.
in well, we
September.
were gonna skip the summer because
Yeah.
it's typically too busy. So
Yeah.
September.
Oh, the other update on the Women's Health Hub, we've moved it to the annex, which is the not walking, but the unattached patient clinic next to the library. So we're much more well equipped, and I really like that space.
It's the better.
It's better than we were at the Northern Ontario School of Medicine building and kind of a slapdash. Let's make this room look like an exam room for medical students. It wasn't ideal. So anyway, we're in a much better space. It was a good place to start.
Yeah.
Anyone else?
Yeah.
I'm thinking about my mom.
Yes.
In the late 70s. Is that something?
It's so interesting. So our hard fast is if you're after 10 years of menopause, you shouldn't be taking estrogen and progesterone. It's dangerous. But with vaginal estrogen, it's actually different. It's different. It's safe into the 70s and the 80s. Yeah.
That's what I said. If you are doing vaginal estrogen, is that not against osteoporosis?
No.
Correct. There's some benefit, but not as much as menopause hormone therapy.
Or
Correct.
gel. Yeah.
Gel,
Patch.
like cream, patch, or pill.
I thought there was a higher dose ring that got more systemic, but I'm not a prescriber. So
Yeah.
for that.
I don't know.
Okay.
I just learned about the term from you.
Yeah.
Thanks for coming out, guys.
Yeah. Thank you.
Are we off of
Thank
this
you,
now?
everybody online.
Nice to not see
I
you,
know,
but
I don't know
you.
how to, I'll stop share. Let's see. Yoink. There. All around.
Thanks for coming out online.
Where? Where'd everybody go? Where? Yeah. All right.
Awesome.
Okay. Bye, guys.